Hello, my name is Natalie Perez Mendez. I'm a fourth year medical student. My presentation is titled SGLT2 Inhibitors What the Internist Needs to Know. Introduction. Empagliflozin or Jardiance, dapagliflozin or Ferixa, and canagliflozin or Imicana are sodium glucose cotransporter 2 inhibitors. They work by inhibiting renal reabsorption of filtered glucose, thereby lowering the renal threshold for glucose and ultimately allowing the patient to urinate out more glucose. The SGLT inhibition also reduces sodium reabsorption, which lowers preload and afterload in the heart and downregulates sympathetic activity. This causes less stress on the heart. This class of drugs was originally approved for type 2 diabetes, adults suffering from type 2 diabetes. That was the indication for their initial approval. However, what makes this class so exciting is that they offer profound cardiovascular benefits in addition to the diabetes control. I want to define HFrEF, or heart failure with an ejection fraction of less than 40%. This is the new indication that was offered with this class of drugs. The mechanisms of benefits are not yet fully understood for this class, but what we do know is that they stimulate osmotic diuresis and natriuresis, thereby decreasing arterial pressure and stiffness, which reduces preload and afterload, and ultimately improves cardiac filling and also stimulates glucagon secretion. Unlike the glucose benefits, cardiovascular and renal benefits are not dose dependent when it comes to this class of drugs. The landmark literature that published these results are the following. First, we have the EMPA-RANK outcome randomized control trial. This compared placebo against empagliflozin, and it showed that empagliflozin had a statistically significant benefit in all cardiovascular outcomes studied. The patient population for this study was patients with atherosclerotic cardiovascular disease and type 2 diabetes. Next, we have DAPA-HF. This compared placebo against dapagliflozin, and it showed that dapagliflozin had a 23% relative risk reduction in cardiovascular death and heart failure hospitalization. The patients cohort in this study were patients with heart failure with the New York Heart Association class 1 through 4 with or without diabetes, type 2 diabetes. And similarly, next we have the EMPEROR reduced trial, which compared placebo against empagliflozin, and it again showed empagliflozin had a 21% relative risk reduction in cardiovascular death and heart failure hospitalization in the same cohort of patients. These patients had New York Heart Association class 1 through 4 heart failure with or without type 2 diabetes. Based on these groundbreaking results, the FDA updated their approval as of August 16, 2021 for the use of these drugs in patients regardless of diabetes status, for patients with HFrEF. And the American College of Cardiologists also followed suit by updating their 2017 expert consensus this year, and it suggests now that that you should use SGLT2 inhibitors for optimization of heart failure treatment in patients with HFrEF with or without type 2 diabetes who are already on first-line treatments such as beta blockers, ARNI, ACE, ARBs, and aldosterone antagonists. I want to go over some warnings and adverse side effects to keep in mind. Empagliflozin and canagliflozin should be used with caution in patients with a GFR of less than 30. And dapagliflozin should be used with caution in patients with a GFR of less than 45. Now, there's a very long list of side effects that any medication may have, including these, but the following are ones I want to specifically emphasize. Because these drugs cause the patient to urinate out more sugar, this allows for a breeding grounds for more bacteria and other flora. So genital mycotic infection is probably the most common thing you'll hear your patients complain about. And unfortunately, this could lead to itching and scratching, which could open up the skin to more invasion, microbe invasion, and ultimately to complicated UTIs and urinary discomfort. So remember to counsel your patients on hygiene. The importance of hygiene cannot be emphasized enough when it comes to this class. And of course, diet, because the more sugar they eat, the more sugar they will be urinating out. when taking these medications. So those two components are super important to counsel your patients on. Lastly, the cost. The cost is not cheap. This class of drugs is relatively new, so they're still very expensive. It could cost you anywhere from $514 to $530, give or take a few dollars, for a 30-day supply. However, it's important to remember the profound benefits this class of drugs offers, such as glucose control, improved heart failure outcomes, improved renal function, weight loss. These things may be worth the initial upfront cost that these drugs present at this time. $500 and so dollars is much cheaper than paying for the complications that diabetes may lead to, or paying for an extended hospital stay due to heart failure exacerbation. So it's important to weigh the cost benefit pros and cons when prescribing these medications, and I would argue that the cost may be worth it for many patients. Lastly, for any audio learners, these two podcasts are highly recommended. They're very educational, they're short, and they're concise, and they really offer an abundance of information on a really exciting class of medications. These are my resources. Thank you very much for your attention.